Welcome, everyone, and thank you for joining us this afternoon. My name is Lynette Trickey. I'm the Senior Vice President of Development and Community Impact here at the American Heart Association. The AHA and OHSU have joined forces with the goal to reduce cardiovascular death, heart attack, stroke, and heart failure in our communities. A couple of housekeeping items for today. Today's discussion is a webinar. And even though we can't see you, we do want to hear from you. So please put your questions and comments in the chat box, and we will have time at the end to go through them. Make sure to choose all panelists and attendees in the drop-down menu so we can see those. It is now my pleasure to introduce Anthony Mulholland, the Senior Director for Heart and Vascular Services at OHSU. His tenure at OHSU has spanned 16 years. He has held positions as a CV ICU charge nurse, a nurse administrator on duty, and nurse manager of cardiovascular intermediate care and telemetry. Please welcome Anthony Mulholland.
Thank you so much, Lynette, and welcome everybody. Good afternoon. Thanks for joining us for our 7th Heart Failure Workshop. And I'd like to start by thanking my team at OHSU and our speaker for today's event. This group has been working on developing a program that really highlights the benefits of looking at heart failure holistically. I also want to thank our friends at the American Heart Association who work tirelessly to improve heart and brain health for everyone. I'll give you a brief history on the creation of these workshops. OHSU and the American Heart Association made a commitment to join together, as Lynette told you, over 3 years ago to specifically address heart failure. Through our partnership, we've developed many patient information materials on heart failure, a heart failure online hub, and we've produced these education sessions that rotate, reaching the lives of those living with heart failure and their families who support them, and sessions tailored to educate healthcare providers. Some of you may have attended our previous sessions. Welcome back. Today, our program will focus on cardiac rehabilitation and exercise for the heart failure care patient. So I'll kick us off with a great big thank you for joining, and I'll introduce you to Dr. Noriko Yamaguchi. Dr. Yamaguchi is board certified in geriatric physical therapy and is also a certified strength and conditioning specialist. She has experience in all practice settings, including acute care, skilled nursing, home health, clinical research, and outpatient physical therapy. Dr. Yamaguchi's holistic approach to physical therapy integrates principles of physical rehabilitation, strength and conditioning, and health promotion, which she feels is particularly well matched to serve patients with chronic and complex health conditions, such as heart failure, oncology, chronic pain, connective tissue, long COVID, and autoimmune diagnoses. Dr. Yamaguchi is highly committed to health, social and environmental justice, and brings a trauma-informed equity mindset to patient care, scholarship, and physical therapy education. She has presented nationally on inclusive and equitable teaching in DPT education and has specific scholarly and advocacy interests in the integration of the humanities into health sciences, community-focused health initiatives, and planetary justice. Welcome, Dr. Yamaguchi.
Thank you so much, Anthony, for that introduction. And if we can get the slideshow up again, I will get started. And thanks so much for having me. I hope that this presentation provides some meaningful information and things you can carry forward with your patients. All right, so course objectives today, we're going to do a review of up-to-date concepts related to cardiovascular exercise and focus on the benefits of exercise and physical activity as a whole on physical well-being. So you see a list of the topics that we will be covering from really differentiating what is the difference between physical activity and exercise, doing a bit of exercise physiology review in terms of what happens physiologically. And I will cover some exercise assessment and current exercise recommendations, and then talk about where cardiac rehabilitation fits and how it helps with the patients with heart failure, and have ample time for question and answer and discussion. So let's dive right into physical activity and exercise. So, oops, okay, there we go. So physical activity is just defined as any kind of bodily movement that increases energy expenditure above the basal level. So anything that we do in life where we're moving our bodies, whether it's things at home, whether it's things at work, or out in the community, what counts as physical activity. So things like this aren't physical activity. And, even though we might be increasing our basal metabolism from the increased cognitive activity from doing our work in front of the computer, and there might be a little bit of increased basal metabolism from typing away on your laptops or using the mouse. Those aren't really considered physical activity because it's not this gross motor bodily movement. I do want to emphasize, though, that these activities are obviously really important, right? We need to be participating in non-physical activities for pleasure, for recreation, to do our jobs, and also for recovery and rest. So the idea here is that it's not an either or, but a both, and that we need these types of activities as well as physical activities for a healthy well-being. So when we think about what exercise is, then we're defining exercise as the planned and structured movement that's used to improve or maintain physical fitness. So there's an intentionality to exercise, whereas physical activity is anything else we might be doing that's not specifically intended to improve or maintain fitness. The great news is that exercise also just feels really good, or it should, and it should be really fun, right? And, my philosophy is that all types of bodies have the capacity to feel really good with exercise. And so my role is to really help our patients find what that exercise is that makes them feel good and that is fun and meaningful to them. So lastly, when we think about physical fitness, it's really this ability to carry out daily tasks with energy, but then still have extra energy to enjoy leisure time pursuits and also to meet unforeseen emergencies. Okay, so let's take a look at this graphically. Here we have a graph that shows on the y-axis physical capacity. So that could be things like our muscle strength, our endurance, or flexibility. And then the green line here indicates how much of that physical activity or how much do we need to do just like our regular daily lives. The red line indicates how much physical capacity do we need for those emergency situations, right? Those unforeseen things where we need to kind of extend our bodies a little more. So if we have enough physical capacity, so we have the strength, endurance, flexibility to do all of it, the above, and still have extra left over, we would consider that to be fit, right? We have that ability to handle all of those situations. So in a situation where we have plenty of capacity to handle all the demands of daily life, but we're just a little bit not have enough, we don't have enough strength or we don't have enough endurance to handle those emergency situations, we're kind of mostly fit, right? And then we have situations where we just barely have enough to handle daily life. And this would be considered an individual that's not fit because they don't have that extra reserve capacity to handle above and beyond what their daily life requires. So they're kind of maxing out every day with just regular life. And then we have certain patients who don't even have the capacity to handle daily life. And that would be our patients who are deconditioned. So when we look at our economies and societies today, it's become more automated and people are globally experiencing a deficit in physical activity. So this is a map from a study published in 2018 using 2016 data. And it shows the prevalence of insufficient physical activity in men. And you see that in the United States, the prevalence of falls into the 30 to 39% category of men who are experiencing a deficit in physical activity. And in women, the prevalence falls into the 40 to 49% category in terms of the prevalence of women who are experiencing a deficit in physical activity. And there are a few factors here that likely explain this pattern, because you see that in many countries, women have a greater deficit in physical activity compared to men. So, some hypotheses might be that women are in fewer highly physically demanding jobs compared to men. So they're not getting the same level of physically demanding activity just with their daily work. Culturally, There might be some less socially acceptable norms in terms of women doing arduous labor or doing very vigorous types of recreational activities. And we also need to consider demographics, and that women do have longer life expectancies on average, so that in the population, the older women who are now more sedentary because of increased age may be actually skewing the entire population of women into less physical activity. So lots of different reasons, but an observation that we see. So just to review here, remember when I use the term physical activity, I'm referring to anything that gets our gross motor skills moving and gets our metabolism above the basal level. When I use the term exercise, I'm thinking of things that are planned, structured, and used specifically to improve or maintain fitness. And when I talk about physical fitness, it's that ability, or the body's ability, to carry out daily tasks, but then also have extra energy to enjoy leisure as well as to meet unforeseen emergencies. So we're going to switch into the physiology of exercise now. So hopefully this will be a good review of exercise physiology. So what happens when we exercise? So this is a figure here that shows the relationship between cardiac output and power as measured by watts. And so what we see is that as our workload increases, so our bodies are generating more power, cardiac output also increases. And since cardiac output is determined by heart rate as well as stroke volume, we expect that all three of these variables will increase as workload increases. So the take-home point here is that the intensity of the exercise does matter, right? Because that's going to be influencing how hard the heart is working. So more and harder doesn't necessarily mean more therapeutic, right? And we have to keep in mind that higher intensities of exercise might not be suitable for all people. And we'll be coming back to this idea of exercise dosage frequently during this presentation. So in this graph, we're going to be focusing on the bold line. So here we have on the y-axis oxygen uptake. So how much oxygen is our body taking up? And then the x-axis is still power. So how much power are we generating measured in watts? So as you can see from the black line, as power goes up, so as we are generating more power, our body is putting out more watts, and our oxygen uptake is increasing. And since oxygen is what's fueling our cellular metabolism. But you'll see that at some point here where the arrow says VO2 max, that's the maximum amount of oxygen our bodies can take up in order to generate power, right? So the fitter we are, the higher our VO2 max, because the fitter we are, the more oxygen we're able to take in and the more power we're able to produce. So the way this applies to our regular lives is that the fitter we are, the less taxing physical work is on our bodies. So for example, let's say that you have to do a job that requires 100 watts of energy. So if you're the person on this bold line, your max is actually about 220, 225, somewhere in that range, right? And so a job that requires 100 watts isn't going to max you out at all, right? But what if you're the person on this blue line and your VO2 max is closer to that 100-watt range, right? That means that that same job that takes 100 watts is literally maxing out your whole body. And you can kind of foresee how in that situation, you might be setting yourself up for injury. So our body also responds from an immune perspective to exercise. What we know is that moderate level intensity enhances immune function, but hold on here, high intensity exercise decreases the function of those immune cells. So again, the intensity matters not just in how it's impacting our cardiac output, but also how it's impacting our immune response. We also know that overtraining and over-exercising can decrease immune function. So again, take-home point here is that how much and how intense of exercise we do does matter, and we have to think about that when we're recommending exercise. So we're familiar probably with the cardiovascular effects of exercise, but let's just kind of think broadly about how just having a more physically active life can be helpful too. So we're thinking about physical activity as a whole, not just structured exercise. And so this figure kind of summarizes the response from the heart, the blood vessels, and the blood level. And as what we see is that increasing physical activity has various positive effects on the heart, on the blood vessels, and even on the blood itself, right? And that all of these positive effects of having more physical activity decreases cardiovascular mortality. And so if we think beyond just the heart and the blood vessels and the blood, this table summarizes other types of benefits of cardiovascular exercise, including reduction in systemic inflammation, reduction in visceral adiposity, and improvements in endocrine function with improved insulin sensitivity and improved mental health. So again, cardiovascular fitness has benefits to physiology, but then we also see on this table at the bottom that there's also a reduction in risk reduction in different illnesses. I do want to point out that there is a typo or a mistake on this table. So this was taken from a paper published in 2015, and you'll see in the first column here, it says increased myocardial infarction. And I just want to clarify in case anyone saw that and kind of your eyes lit up, that should say decreased myocardial infarction on that slide. So just an error in that part of the table, but I think this does a nice job of summarizing a lot of the physiologic benefits as well as the risk reduction in different diseases. And so like we touched on, there is a key benefit to mental health when with cardiovascular exercise as well. So this table shows the effect of participation in a formal cardiac rehabilitation and exercise training program on the prevalence of depression, anxiety, and hostility in both younger and older patients with heart disease. And so the white bars indicate that prevalence of these conditions before participating in a cardiac rehab program. And then the gray bars indicate the prevalence of those conditions after participation. And what you can see is that in both the older and the younger populations, and these are patients with heart disease, the prevalence of depression, anxiety, and hostility decreased across the board. And so again, having a cardiovascular exercise program benefits mental health as well as physical health. So take-home points here, right? Participating in cardiovascular activity is really helpful, right? It improves a lot of different things physiologically, everything from just your cardiovascular function, better lipid profiles and glycemic control. It can boost your immune system. It can enhance your mood. But like everything, you can always have too much of a good thing, right? So we have to keep in mind that overtraining or excessively high intensities of exercise can impact the immune system in a negative way that we don't want to, because those things do create prolonged physiologic stress on the body. And so one of the themes that we'll be emphasizing today is this idea that exercise is medicine. And so just like medicine, you need the right type and the right amount to dose it appropriately. And that underdosing exercise might lead to insufficient outcomes, but overdosing and overprescribing exercise can also lead to adverse effects, including things like overuse injuries. So let's now talk about exercise assessment, and we'll focus on heart fitness. So a great way to start in terms of assessment of physical fitness is to ask two simple questions just to gauge how much activity people have during the week. So the questions you would ask would be, how many days a week do you do moderate or vigorous intensity activity? And then how many minutes do you spend doing it? So with this, you can calculate the total volume of moderate to vigorous intensity physical activity that somebody does during the week. And this can generally estimate somebody's physical fitness, because the assumption is that the more time you spend doing these things, the fitter you likely are. And this is a nice starting point in order to set safe and achievable goals for how much that we can improve. The DAISY, the Duke Activity Status Index, has been used primarily in the cardiac patient population. At OHSU Rehabilitation, we actually have also started using it with other patient populations where improving physical fitness and physical capacity is one of our rehab goals. And so for those patients, we have also been starting to use this index as well. So as many of you probably know, it's self-administered and asks patients to rate whether or not they can do these activities. And the nice thing with this scale is that you are able to calculate the estimated maximum metabolic equivalence, or METs. And one MET is considered your resting metabolic state. So if your maximum METs is a bigger number, that means that you are fitter because you can handle more vigorous activities. The Duke is used a lot, and there's actually this nice calculator that you can use online. And so this link, you click on it, and then you just enter in your patient's answers, and it'll automatically calculate for you what their maximum METs is and what their total score is. And so it's a nice resource to have if this is a scale that you do use regularly. So from the self-report that we have of the patient's self-reported physical activity, we can estimate about what their physical fitness might be. And based on that, we can select a performance test to actually test their fitness. And there's so many different types of tests, right? From ones that you do in the lab, others that you do on an athletic field. So it's really kind of up to you and the type of clinic that you're in to figure out what kind of clinical assessment is going to work best for your space. And so the ones I'd like to share with you today, a couple tests that we can do in a physical therapy clinic. One is the 6-minute walk test. So as the name implies, this is a walking test that's used to assess a patient's walking endurance and physical capacity in the aerobic sense. And then there's a 2-minute step test. The really nice thing with this is the patient is marching in place. So you don't even need like a long hallway to do this test. You can just do it in an exam room because the space requirement is so little. All they need to do is march in place. There are some treadmill tests that are clinically appropriate that we can do in an outpatient setting. The talk test is one that is used to determine the patient's ventilatory threshold, which is the point at which your breath rate has to kind of get higher and higher in order to keep up with the physical demand of the exercise. So if you're under your ventilatory threshold, you can still talk and do your thing. You might not be able to sing though, okay? But if you're above your ventilatory threshold, then the cadence of your talking changes. And so you have to breathe faster. And so, your sentences are going to be cut short a little bit as you're talking to accommodate that faster breath rate. Now, there is also a single stage treadmill test that is modified from the Bruce protocol that has the multiple stages. The hyperlink I have in here in this slide actually links you to a Google sheet that I created so that you can enter in your patient's performance, and it'll automatically calculate for you their estimated VO2 max. And this is a validated shorter version that's just one stage that is more clinically applicable than doing an entire Bruce protocol. So let's turn to recommendations for exercise now. So like I mentioned, this idea of exercise as medicine was developed by the American College of Sports Medicine. And the idea is that just like any other medicine, exercise needs to be prescribed and dosed appropriately in order to have that positive therapeutic effect for our patients. And of course, the difference here is that everybody needs to be taking this medicine, right? It's not just something that we do when we get injured or when we get sick or when we're not feeling well. This is the kind of thing that all of us should be doing to maintain our health and to stay strong and to experience that sense of well-being. So the American College of Sports Medicine has published physical activity guidelines for Americans, and this is the table that summarizes their recommendations. Couple things I want to highlight here is you'll see that for the older adult 65 plus population, the physical activity recommendations are the same as for adults, as long as their physical ability and their health conditions allow. So it's the same things, and they suggest potentially adding some balance training or other types of activities as well. You'll also see that the recommendations for physical activity for children and adolescents is actually a greater volume than for adults. And that's because there are huge benefits of exercise on gross motor development and on cognitive and emotional development and physical growth in kids and adolescents. And so for everyone, we should all be sitting a little less and moving a little more because any little bit of activity counts. And so, the idea here is to promote movement, not just exercise. So when we are thinking about these guidelines, we need to be able to assess whether our bodies are working moderately or vigorously. And you can use a verbal description like noticeable, light, heavy, almost maxed out. But you can also use a numeric scale, similar to how we use a numeric pain rating scale. So when we're thinking about cardiovascular training, light intensity means that you can talk and you can sing, right? So it's really light. It's not affecting your breath rate. It's probably not increasing your heart rate too much. Moderate cardiovascular training means that you can still carry on a conversation pretty normally. It's not changing your breath cadence that much, but you wouldn't be able to sing because you can't, hold those long arias in the same way. And then for vigorous or high intensity exercises, that's when you are working hard enough where you are not really that interested in carrying on a conversation. You're really focused on your breath, and you're well past that point of being able to talk and walk at the same time. Now, when we think about resistance training and the rate of perceived exertion, you can think about that in terms of how much effort are you putting in to do that set of weight training exercises. However, there's another way that you can think about the rate of perceived exertion for resistance training, and that's something called repetition in reserve. So, the focus today is on cardiovascular exercise, but I do want to mention the value of resistance training as an important part of maintaining physical fitness, and that's including for our patients with heart failure. So in resistance training, the intensity of exercise differs depending on what your muscular goal is. So the way that we do resistance training to gain muscle strength is with different dosage than if we were going to improve muscular endurance, for example. So in this case, the rate of perceived exertion is more related to how many reps do you feel like your muscle has left in it? And that is then translated into your rating of exertion. So for example, if I was going to do a bunch of bicep curls, right, and I don't have any weight in my hands, I can do kind of a lot of them, right, and not fatigue too quickly. And it's not very hard for me. But if I put a 10-pound weight in my hand, now it's like, oh, that's really heavy, right? So then I start doing my bicep curls and I get to the point where I think I can only do 2 more, right? That is my 2 repetitions remaining, which actually equates to an 8 out of 10 repetition in reserve, right? So I can use this table to kind of help to dose how intense of an exercise I'm doing. So for patients who have heart failure, there are exercise recommendations. And this year, the American Heart Association did publish guidelines on the management of heart failure. And the American Heart Association states that for patients with heart failure who are able to participate, exercise training or regular physical activity is recommended. So it's not contraindicated. And this is to improve functional status, exercise performance, and quality of life. The American College of Sports Medicine also has guidelines and recommendations on the type of exercises that is recommended for patients with heart failure. So aerobic or cardiovascular training and strength training make the foundation for an exercise program with patients with heart failure. Additional activities such as stretching for flexibility, yoga, Pilates, Tai Chi, all of those things offer excellent benefits, such as improving your mobility and your balance and practicing mindfulness with movement. However, those themselves by itself won't be providing enough cardiovascular and muscle conditioning to directly strengthen the heart and the skeletal muscles. And so they're nice complements and might be a nice entry point into patients on developing an exercise program. However, the ultimate goal is to establish a nice program that includes aerobic as well as strength training. Okay, so let's think about prescription here. Okay, so if exercise is medicine, then we need to prescribe it thoughtfully to maximize potential benefit and then minimize adverse effect. And the FIT acronym is really helpful to make sure that we are thinking about all elements of prescription. So F is for frequency. How often do you do it? I is intensity. How hard are you doing the exercise? Time, how long of exercise do you do? And then what type, right? So type of exercise that you're doing. And so when you're thinking about exercise prescription, you want to at least consider these 4 variables. So let's look at some examples here. So in this first example, the type of exercise is walking, right? 30 minutes, 3 times per week. So I have my time, 30 minutes, and my frequency, 3 times a week. And so I'm going to do it at a moderate pace. That's my intensity. And moderate, I mean about a 3 out of 10 on a 0 to 10 scale. And I can gauge that because I can talk, but I can't sing while I'm doing the walking program. Okay. For a different example, it's a different type of exercise. So balance exercises would be the type of exercise. I'm going to be doing 15 minutes of balance training 5 times a week. So I have my time and my frequency. The intensity of balance training is considered to be this like challenging but doable kind of scenario where it's not super easy, but it's not super hard. And that just right challenge is the target intensity for balance training. And then the last example I have here is more for resistance training or weight training. Let's say you're going to do it for your upper body 3 times a week is my frequency. I'm going to prescribe 10 repetitions per set at 2 reps in reserve. So the 2 reps in reserve is my intensity. The 10 reps, 3 sets, 2-minute rest break between sets then would be the time, quote unquote. So again, instead of time here, we're using the reps and sets for resistance training. Okay, so there are other considerations outside of FIT, right? So let's briefly touch on those. For example, do we recommend that patients do a home program or an in-clinic exercise program? So there was a study published in 2017 that did find that a home-based cardiac rehabilitation program can yield similarly effective results as in-clinic programs. The one thing I want to note about this study is that because it was a structured cardiac rehab program, the people doing the home program still had many touch points with their providers about how the program was going. So it wasn't like they were just given a list of exercises to do on a handout and told good luck, right? So they were getting multiple touch points. They were just doing the exercise at home instead of in the clinic. Do we recommend our patients do an exercise program inside in the gym or outside? What we do know is that air pollution can negatively impact cardiovascular and cognitive performance. And so thinking about air quality is going to be an important consideration here. With that said, daily exercise and daily movement is still better than none at all. So this is the take-home point here is we need to find alternatives when air quality might prohibit patients from safely exercising outside. We will need to come up with some indoor options because some movement is always going to be better than none at all. When it comes to interval training versus continuous intensity training, there was a study published in 2020 that found that group interval training resulted in larger improvements in a cardiac rehab program compared to the group that was doing continuous intensity. So by this, I mean intervals mean that you do something that's a little more intense and then a little less intense and then a little more intense and a little less versus the continuous intensity is just spinning at the same intensity the whole time. So this study did find that there may be some benefits to fluctuating and tinkering with the intensities during training. And then other considerations to think about too, or that I like to think about in the strength and conditioning world and in the athletic populations, there's this concept of periodization, where over the course of, let's say, a year, you cycle in and out of different types of training regimens. And, research on using this idea of periodization in physical rehabilitation with patient populations hasn't really taken off yet. Research in periodization and the benefits of it is really limited to the athletic and sports population, but, kind of like to think that just living life is like the ultimate triathlon, right? So if you take that athlete's mindset and apply it to patient populations, I think there may be some nice potential for some scholarly work in the application of periodization with our patient populations. And then there's this idea of cross-training. So this is the idea that you're not just doing the same kind of workout all the time, but you're varying it up. And the same study that I discussed in the previous slide showed that an interval training program that also had multi-joint and multi-planar exercises was beneficial, right? So instead of just doing that continuous intensity on an ergometer, doing interval training using multi-joint and multi-planar exercises did have better outcomes. And so this idea is that, variety might actually be helpful, right? So exercise is medicine. Let's summarize some take-home points. First and foremost, any kind of exercise is better than no exercise at all. So, I really bring this into the clinic and into patient care where, for me, I do think that it's my job to figure out what kind of activity the patient is going to be willing to do, because it's so much better to do something than nothing at all and just mark that the patient was, refusing, right? So this is where we can use our creativity to figure out what kind of exercise or what kind of activity the patient will be willing and motivated to participate in. We know that exercise prescription is not one size fits all. So you can't just print out a protocol from online and hand it out to everybody, right? We do need to take a more individualized approach. And when we're thinking about exercise, we have to think about it as it relates to the optimal dosage as well as consistent adherence. Our bodies take some time to adapt. And physiologic adaptations and getting fitter can take weeks to months. So it's not just a workout once and then you're fixed kind of thing, right? We need to consistently be participating in physical activity and exercise in order for positive physiologic changes to occur. And we know that our bodies work on a use it or lose it kind of system. So the physiologic gains we made are going to be lost with detraining, right? So again, this idea of sustainability in an exercise program is a really important consideration, which means that exercise prescription requires that shared decision-making with the patient, right? The prescription isn't about us as the expert telling the patient what to do, but because exercise programs require consistency, which means it needs to be enjoyable and something that the patients want to do, we need to work together in order to develop what that program might look like. So now let's talk about cardiac rehabilitation specifically. First off, what is it, right? So this information on this slide I took directly from the American Heart Association website about cardiac rehabilitation, and I want to highlight a few key features here. First off, cardiac rehab is medically supervised, okay? And so patients are getting supervision and monitoring while they're exercising. And there are three components to this. There's exercise counseling, so really teaching patients about principles of exercise and then doing the training. But there's also education for heart healthy living, because we know that it's not just about working out that'll keep our heart healthy, right? There are other elements to good heart health. And then also counseling on stress reduction, because we know that stress is harmful for our whole physical body, including our heart. So this is a sort of picture description of what cardiac rehabilitation is. And this is coming from a paper published this year, actually, that summarizes all the different roles that cardiac rehabilitation can play in improving cardiovascular outcomes. And I love this because it really shows you how many elements could be incorporated, which means that for any patient, you have a different entry point into this, right? And so it can be anything from tobacco cessation to the exercise component, to the nutrition, to the blood pressure management. So there are so many different entry points into starting to get patients motivated to improve their overall health as well as their heart health. And it's not meant to be overwhelming because there's too many things going on, but really it's about ensuring that the idea of caring for your heart is really actually caring for your whole you, right? And that it's not just about one thing. So when it comes to the benefit of cardiac rehabilitation, there was a meta-analysis done in 2019 that showed that cardiac rehabilitation can reduce hospital admission for heart failure, as well as improve health-related quality of life and reduce mortality. So we do know that participating in cardiac rehabilitation can help with health outcomes. And so in general, cardiac rehabilitation can be thought of in 3 different phases. The phase 1 begins while you're in the hospital. So if you were hospitalized for acute heart failure, your recovery is starting while you're already there. Phase 2 is happening in the outpatient setting where you're going through this medically monitored, supervised exercise program. And it's for most cardiac rehabilitation programs, it's about 3 times a week for 12 weeks. And then phase 3 is when you're entering into more of a long-term maintenance program, maybe at the gym, or maybe helping you get set up with community exercise facilities and things like that. So next steps from here. If something like this seems like it would benefit you or your patients, then this is something to discuss with your cardiologist or primary care physician to get that referral for cardiac rehabilitation and initiate that intake process to get started in cardiac rehab. The link I have here links you to various cardiac rehabilitation programs in the region. And so you can look up, which programs are closest to where you are. And there are multiple sites available online for support as well as for more information. A lot of this that I took from the American College of Sports Medicine is linked here. And the ACSM does have exercise guidelines for other types of health conditions as well, not just heart failure. So that would be a good site to look at if you are also working with other types of patient populations. And then Organ Heart Failure Guide, as well as the Knight Cardiovascular Institute. Okay, and that is what I have in terms of presentation. I'd love to open it up for question and answer at this point.
Thank you so much, Dr. Yamaguchi. That was an exceptional talk. I learn something every time I hear you speak. I'd like to introduce Jane Mitchell, who's going to be facilitating our Q&A session. Jane is a nurse practitioner and instructor of medicine in the Division of Cardiovascular Medicine at OHSU, and she's been a nurse since 1979 and nurse practitioner since 1993. As a very active provider in the heart failure space in our region, Jane has co-created many of these education sessions with us since we began producing them. She specializes in the care of heart failure patients, as I said, and specifically transitional care and patient outcomes. Jane, thanks for taking over the Q&A.
Thank you so much, Dr. Yamaguchi. That was amazing and wonderful, and it just makes me want to go out and exercise. So we have a couple of questions, it looks like, in our chat group. And if you have any questions, now's the time. Annabelle looks like she wrote, will Medicare someday cover cardiac rehab for our HFpEF patients? And as you know, our heart failure with preserved ejection fraction patients are often times the very ones who need cardiac rehab, and because they usually have some pretty significant comorbidities. So do you have an answer for that?
Yes, if only we can unlock what Medicare is thinking in terms of what they're going to decide to reimburse us for versus not. So my best suggestion for you, because I have no idea if Medicare is going to eventually cover this, is that, as a physical therapist in a physical therapy clinic, we can work with patients who have functional mobility deficits that is covered by Medicare. So they might not qualify for cardiac rehab as a separate rehabilitation service, but they likely will qualify for physical therapy services, in which case they would undergo sort of this one-on-one physical therapy intervention. And the physical therapy goals in this case would be to improve functional endurance and things like that. So that would be sort of the workaround to can't go to cardiac rehab. And I think that might actually help to answer another question that came up in the chat about, for the patients who don't meet the criteria for cardiac rehab, like what are the alternatives? And the alternatives would be, most likely it's going to be much safer to refer them to physical therapy in the clinic for that level of exercise prescription versus recommending that they go to, the local gym or to work with a trainer, particularly in the beginning, if it's their first time exercising. And then once they understand more about what is safe versus not safe, what's overtraining, what's the right amount of training, then that would be a good time to potentially transition them into a community exercise type of program.
Absolutely. Great. Thank you so much. So I think you covered Elizabeth's question about as far as what to recommend for the patients who don't, what about the patients who don't fit the criteria for cardiac rehab? And I think that covers that. The other question is, how soon after an acute heart failure hospitalization can a patient start outpatient cardiac rehab? I know the answer.
Yes, please go for it.
My understanding is that it's 6 weeks. And the reason that it's, although some of the insurances will let the patient go earlier, the thought process behind the 6 weeks, especially in the heart failure with reduced ejection fraction patients, is that we're actively up titrating the medications during that time. And what you don't want to do is to send a patient in to go walk on a treadmill to pass out because you've got their blood pressure so low. So it takes a little while to adjust those medications. So I think that's why Medicare says 6 weeks. Now, typically we will prescribe cardiac rehab at discharge. And it takes about 6 weeks for the patients, for us to get them set up, et cetera. So that works out well. And then remember, if your patient also has ischemia, you can do cardiac rehab anytime. So they can go the next day.
And then if I can also add, oftentimes as part of the patient's discharge plan from acute care, we often do recommend home health physical therapy as that transition to maintain that continuum of care prior to starting any kind of outpatient rehabilitation. So, what we don't want happening is that patients are getting some physical activity from nursing and physical therapists working with them in the acute care setting, and then they discharge home and they're just waiting around, not knowing what's safe to do and what kinds of things are okay to do. And they, end up being too sedentary while they're home, while they're waiting to get started. And so, to prevent that from happening, home health physical therapists can come in to monitor their physical activity and to provide some guidance into that while they're in that transition period.
That's a great point. Thank you. Annabelle also wrote that Samaritan Health Services does offer a transition program, which is self-pay. And I believe that a lot of the different programs do. The patient for like $50 a month or whatever can go continue to exercise after they're in phase 3, right? And then this is a good one. Any suggestions on how to motivate patients, not necessarily heart failure patients, to start exercising on their own?
Yeah, I mean, I think
we're retiring.
Probably all of us have kind of asked ourselves that, right? Just for ourselves and keeping our own motivation for staying active and fit. For me personally, I use a lot of motivational interviewing to really get a better understanding of where patients are at in terms of thinking about health behavior change. And there's nice work done actually on the application of motivational interviewing to adopt exercise programs in this patient population, in a cardiovascular patient population. So I think really tapping into a good understanding of where they're at in terms of health behavior change is sort of the starting point. Because if you don't know if your patient is contemplating it or ready to make an action plan, all of your advice and sort of encouragement could just not be targeted to where they're at in that continuum of behavior change, because, you know, especially for me, I really value the sustainability of wanting to exercise instead of just doing it for a few weeks and then falling off the bandwagon. So really, if we're thinking in the long term, understanding what's going to create that change in behavior so that being physically active and having a regular exercise program is just the way that we start doing life, instead of like the separate thing that we do temporarily and then fall back into different habits. So I think for me, motivational interviewing is a really good starting point. And then the second thing I will say in terms of, you know, getting patients to start exercising is you really can't do it on your own effectively. Right? It's hard. It's really hard to do it on your own, particularly if your social networks and community networks are not built around physical activity, or your social determinants make it so that physical activity and incorporating exercise into your life is just not really that easy to do, right? So the idea that it has to be something that you figure out on your own, I think is oftentimes where people really just don't feel like they can do it. They don't have the bandwidth to figure it out. And, you know, it's really hard to keep it up. So really understanding that that it does take support, and we have to figure out as providers what kinds of supports are needed given the context of the patient's case.
Excellent. And then you also spoke so wonderfully about the fit, right? So of course, while you're doing this, I'm adding it into my ABS. So when I see my patients, I can make sure that with every visit, we're talking about this again, because it does mean a lot coming from providers of, hey, you need to exercise. And this is what I think you could do. I think one thing that I struggle with sometimes is the patients when they're finished, you know, maybe they did cardiac rehab a year ago. And as you know, it's typically a lifetime, it's a one and done therapy, but where they're sitting a lot and maybe they could only do 3 METs on, you know, at cardiac rehab. And then I struggle with, like, I don't want to push them too much, but I don't want them sitting on the couch either. So any suggestions for that?
Yeah, I mean, and I think this is where particularly for those patients who may be functioning at a lower max MET level, or oftentimes I've seen this with patients where, you know, they've never really liked working out, or it's just never been a part of their normal life. And so it's just not something that they would ever, like, you know, when they imagine their life, they don't even think about exercise as being part of it. For those patients, thinking about just how to increase physical activity versus getting them to exercise, I think for me is a nice strategy, right? So oftentimes the idea of exercise sounds really daunting. Like, oh my God, I have to like go put on gym clothes and get to the gym, and then I have to spend an hour there. And, you know, and we often have these ideas of what it's supposed to look like when we're working out, versus if we just are more active throughout the day, that's still better than nothing, right? So again, really reframing what it means to be active, and sort of kind of taking the lens of, hey, let's just move more. I don't care what it looks like, just move more, you know, versus like, you need to exercise, I think is sometimes a helpful entry point for those types of patients.
Excellent. And then, okay, while you're speaking of moving more, what about the watches with the 10,000 steps? What's your thought?
So my thoughts are that, like anything, it can be really helpful, but then depending on our mindsets of how we want to use the tool, it can then end up being really unhelpful. So it's definitely a situation of it depends. So, you know, the origin of the 10,000 steps is that it was a way to encourage people to just increase physical activity during their life. And, you know, for many of us, having that goal or that metric can be a really helpful kind of motivator to just get in more steps, because you want to reach that goal and see the green flashing, like, hooray, kind of congratulatory stars on your app or whatever. And so, you know, there's extrinsic motivation in that sense. The issue is that, like we talked about, it's not one size fits all. So 10,000 steps might be way too much for some people. It might actually be not enough for other people, right? So depending on your current physical capacity and your current level of fitness, it could be over or underestimating how much physical activity you really should be doing. And remember, it's just a metric of physical activity during the course of the day. So you could have swum 5 miles today and have only walked, 1,000 steps, but you have gotten a ton of activity during that day, right? So steps is only one way to measure physical activity, and it's one that can get easily integrated in many people's lives. But if your mode of exercise or the way that you like to participate in physical activity is not using steps, then it might not be the right metric for you.
Thank you again to you, Dr. Yamaguchi, for leading us through today's discussion. It was great. And Jane, thanks for facilitating the Q&A. Always a wealth of knowledge yourself. Thank you to all of the participants who joined us today. Thank you to AHA and OHSU's partnership, and we'll see you all next time.